and welcome to Hear Me, See Me. My name's Bex, and unfortunately, or fortunately, you're going to hear quite a lot of me, a lot from me even today, and I hope that's okay. I have been kind of hired into Autism Bedfordshire on a contract with the NHS, and Tracy, the lovely Tracy, who's going to speak for a bit after me, she is kind of in charge of a programme that's going forward to work out a strategy for learning disabilities and autism across the NHS. And as part of this campaign, we've been talking to loads and loads of autistic people across the east of England, and listening to what they say and where they're having difficulties accessing healthcare services. And we really just wanted to share it with you because obviously you're everyone who is working within and around people. And I think it says something about the amount of people that registered for today, right? I was kind of expecting this to be a very different type of workshop. I was expecting us to have not that many people, for it to be really, really interactive and to be able to talk a lot about people's experiences. But quite quickly, registration spiraled. And I think that really shows the gap here, right? And the kind of the want from you guys to know a little more about what's going on. So I really hope that we can provide some of that in these next couple of hours. I'm going to try my very best to get a break in the middle. We'll see how we go in terms of presentations, but please feel free to kind of go and grab yourself a drink or have a refreshment break at any point. Before we kick off, a couple of housekeeping things. You are all muted, but questions, please do put them in the chat. Each of the presenters, after they finish their sessions, are going to have a look through some questions. But because of the amount of you that I think we're going to have joining today, it might not be that we can answer all of them. And I'll make sure that I come back to you afterwards with a response from the relevant person. The session will be recorded, which I think you have all seen and should have seen the little red light on the top, and then it will be put somewhere where you'll be able to link to it. So should any colleagues or you need to drop off halfway through, you'll be able to access it afterwards. And I'll make sure that that's sent out latest early next week. And yeah, so any questions that we don't have time to talk through will be answered after the session. So the agenda today is packed, as you can see. So we've got a kind of welcome and why this is such a key focus from Tracy, who I'll hand over to in a minute. I'm going to talk through the Hear Me, See Me campaign, which is kind of what inspired this event here today. And in that, you'll get some quotes and some real life experiences from autistic members of ours in Autism Bedfordshire, but also wider, further afield, all through the east of England, and stories from those sessions. We've got some good videos for you to see today. I want to talk through a little bit more about how to support autistic adults. And obviously this is based completely on the findings from this. This isn't a kind of certified training. This is what we're hearing and what people are saying, and we're feeding that back to you. And as I said earlier, there's clearly a gap and a knowledge place that people want to know a little more. So yeah, I hope that will be really useful. Sharon, whose son Miles is a member of Autism Bedfordshire, is going to talk about her experience and Marsik's experience with accessing healthcare services. And she's an incredibly passionate speaker, and so I'm sure that you'll find that really, really interesting. And then initiatives that are currently taking place. We've got Colin and Erica who are going to talk through some of the stuff that is already going on. So without further ado, I'm going to hand you over to Tracy. Have I got you, Tracy?
Yeah, that photo really does stand out. So apologies for the photo. And actually, apologies first of all if my computer makes loads of noise in the background. We've had a few problems with that over the last few presentations, and I'll try and make sure I speak a bit louder so you can get over the noise. So do you want to go on to the next slide? As the slide says, my name's Tracy Brennan. I'm the Senior Manager for Leader and Health Inequalities in the East of England. My role is to make sure that we are ensuring that learning disabilities and health and autistic health inequalities for people with a learning disability and autistic people is being looked at as a priority, and that we are coming up with initiatives, which obviously Bex will talk about later, to ensure that that support is given. So this is just a slide, obviously, without Teacher StockX, where we're actually based. We're covering 6 areas we're in across health. They're based around sustainable transformation programs, so that's STPs, but actually we have a slightly different footprint, and we follow the 6 different local authority based areas. So we look at Norfolk and Waveney as one area, and then we have SET, which is Southend, Essex and Thurrock, and then we have Hertfordshire, and we have BLMK, which is Beds, Luton and Milton Keynes, and then we have Cambridge and Peterborough, and Suffolk as a whole area. So, but we are obviously covering those areas in the east of England. So I just wanted to highlight, really, we did have another conference last week, so I hope some of it isn't just repeating itself, but I think a little bit different. We know how many people there are with a learning disability. We know that because there are GP registers, and GPs put people with a learning disability on those registers in order to make sure that there's good services available to them. But one of the things I really wanted to highlight today, and it's a piece of work that we're really wanting to take forward and are starting to take forward, is that really, in terms of autistic people, we don't know exactly how many autistic people there are in our region. We know there's a lot of people on our waiting list to be able to have diagnosis, and we don't know whether or not, obviously, until they're diagnosed, whether they are autistic. But within GP registers, there isn't a register like there is for learning disabilities. And for autistic people, that's a bit of a frustration, because how do health services know what reasonable adjustments need to be made if it's not recorded somewhere? So I just wanted to highlight that, yes, it's a real problem to us, because we want to make sure that the right information and the right support is given to people, but we don't know who they are until they're registered and identified. So there is coding that GPs can use, and we encourage our GPs at the moment to be able to review their coding and to ensure that that person is noted as having as being autistic if they've got a diagnosis, and at least then we've got some sort of clarity in knowing who we can be supporting in that region, in our region. Do you want to go on to the next slide? So a lot of our work around the Learning Disability and Autism programme, which is a national programme, is based around the long-term plan, and that's the NHS priorities over all health services that was published a couple of years ago, and takes us out to 2025. And within there's some real key objectives for people with a learning disability and autistic people, at the moment, obviously, a lot of work's done around with people with a learning disability. We really need to raise that profile to ensure that it's replicated around autistic people as well. So just a few of those highlights out of the plan. We need to improve community-based support. I would probably say that some of these that we're going to go through need to start improving community support, because community-based support, because improving is maybe a bit misleading for autistic people. There is very, up until now, the work that's been taking place, there's in the past been quite limited services, and we really want to demonstrate that there's work happening to improve the situation. There's a real focus in the long-term plan about understanding the needs of autistic people and their families. That is a real commitment by the NHS, and hopefully you'll see just by the work we're doing with Autism Bedfordshire that is going to be something that we can embed across our region. Obviously, we recognise that from learning disabilities that people with learning disability have poorer health outcomes, and we know that actually that happens as well with autistic people, and we really want to make sure and quantify and qualify what those long-term health conditions that also alongside autism are prevalent amongst autistic people, so that we can make sure that their quality of healthcare is improved. And reducing health inequalities, which is ultimately pretty much all of that put together, really. The other part of the long-term plan priorities for our region is around championing, it says, insights and strengths of people with lived experience, and I think today we're here exactly to celebrate that. the work that Autism Bedfordshire are doing on behalf of our region or in partnership with our region really does demonstrate our understanding and improve our understanding of the issues that are faced by autistic people. And I think that we've just seen, as the last few months have gone on, just how invaluable that is. Probably what's really important is understanding the awareness, making people aware of the needs of autistic people. And obviously some of those autistic people will also have a learning disability, and we want to make sure that all needs are catered for. You want to go on? So alongside that, there's obviously the National Autism Strategy, and there's some key points of work that this is an integrated strategy working with the Department of Health and Social Care, NHSE, and a range of other partners. And there's key priorities within the strategy that, as the strategy is being reviewed and renewed, that we are actually taking forward now. So you can read, and they're over 3 pages, so we can just go through them. It's around identification. There's lots of work taking place at the moment. Do you want to go back on? Sorry, Bex. Identification is a real key. There's pathways being developed, and funding has been allocated to each of the systems, or the 6 systems, to make sure that we improve identification. That understanding of autism and the inclusion across the public sector is really important. I mean, across all services, and as I say, hearing today's information will hopefully help with that. Understanding workforce. So we know that there's huge issues in people having a lack of knowledge around autism, and obviously we're wanting to ensure that does improve, and we know that that's going to take place particularly around the use and the mandatory implementation of the mandatory training for the Oliver McGowan training, and that's due to be implemented about beginning of spring, although at the moment there are the pilot is being evaluated. And when that happens, hopefully what we'll find is that we'll be able to spread that information and share it, so that the actual understanding of autism and inclusion across the public sector will be something that's taken forward. Next slide. We can go on about the health inequalities in our region, but some of the key areas of work that we're doing in order to specifically work around supporting autistic people and understanding that those health inequalities that we mentioned earlier is the LEADER programme. So I oversee the LEADER programme for the East of England. The LEADER programme is now called Learning from Life and Death of People with a Learning Disability and Autistic People. Now, we're not getting at the moment notifications for autistic people if anyone dies, but that will happen towards the end of this year, maybe the beginning of next year. And the intention is that then from those notifications and reviews of people who have passed away, that we'll be able to understand what could have been done better. So it's not an investigation or a safeguarding, it's purely to identify where those trigger points were that we needed to improve services. So that should start soon. There is also various trials going ahead. Obviously, if you're working with people with a learning disability, you'll have a very familiar understanding of the annual health check. There is something that's being trialled up in Newcastle around the development of an autism health check. We should have the results of that probably towards the end of next year. So we want to make sure it's right. We want to see that it's of value to the individual, and there's pockets of work being done just to see what the output and the improvements of an autism health check would, and the benefits of an autism health check would be. For those that don't know about STAMP, that's Stop Over Medicating People with a Learning Disability and Autistic People. There's a lot of work that's taken place already around people who have been in hospitals and long-stay institutions where they might have been on a range of antipsychotics and antidepressants, so the psychotropic medication, and about how we can reduce that. Obviously, there's a lot of physical health implications as a result of those medications, and we know that some people just don't need them. We're doing various studies to look at how many people are on antidepressants, because although we are working with the inpatients and mental health services around people being on those medications, actually GPs and practices are often the port of call for an antidepressant, and so we need to go and look back and find out how they came to be on those medications in the first place. We've got a little way to go around supporting autistic people around the medication and the Stop Stamp programme, but it is something within our region we're wanting to concentrate on, because I think with learning disabilities, as I say, there's a lot of specialist services, whilst autistic people tend to be linked much more with mental health services. The programme isn't as familiar in those services. There's also a piece of work that's happening as a trial. We're actually working with Hertfordshire on this trial around identifying a reasonable adjustment flag, and that is where anybody that uses a health service would recognise this flag and then know that person has a disability. It should be available for all people with a disability, but at the moment with the trials we're doing, we're concentrating on people with a learning disability and autistic people in terms of whether or not the flag programme would work. I suppose whilst the digital part of it will be the ultimate goal, I think the first port of call and probably the piece of work we've really got to concentrate on is people understanding their rights. And I know that, again, that's what Autism Bedfordshire are working on doing with people. So first, understanding what the Equalities Act is about, what reasonable adjustments they can receive. But likewise, on the other side of that, for staff and workforce to know what a reasonable adjustment looks like. Sometimes staff will only know what they know, and trying to be innovative without the information is really hard. So it's a two-way strategy. It's about trying to make both workforce familiar with reasonable adjustments, but also ensure that people feel empowered to be able to say and stand up and say that, I need more help with a particular element of support to access health services. And around the mental health side of things, there's improvements in crisis prevention. In order to stop people going into inpatient units, there's obviously a huge link and increase in autistic people being placed into mental health settings, and we really need to avoid that. That is not the way in that we should be supporting people. And so there is a lot of work happening with that. And once people are in hospital, around making sure that they're discharged. So that's the National Autism Strategy. Do you want to go on to the next slide? And I suppose what we are, when we're looking at those conditions, is identifying what the comorbidities are. So what other conditions are there for autistic people that we need to be aware of and be able to make sure the right pathways are in place. So it's recognised that autistic people are also more likely to have dyslexia or dyspraxia. They're likely to have more issues around sleep deprivation and insomnia. Obviously, probably a key area that we recognise is around the mental health issues that people face, and that can also be incorporating issues such as anxiety, but likewise eating disorders, that kind of thing. We know that there's a high prevalence of people who are autistic people also having learning disabilities. And the other area alongside mental health issues, which we'll be looking at, is epilepsy. There is a connection between the two. But the thing that's when we're looking at all these conditions is that there just isn't enough information out there. There isn't the evidence, and we don't have the feedback from people to know what exactly we can do to improve the situation. If we look at learning disabilities, and I've worked much more in learning disabilities for the last 30 years, and within that worked with autistic people, actually we've got loads of reports telling us what's going wrong with people with a learning disability, but we really need to understand, in order to improve the situation, what's happening, what the experiences of autistic people are. Do you want to go on to the next slide? So in our region, we've made a few commitments, but at the top there, probably what's really important and what I think I feel quite passionate about and why we're here today is listening to people with lived experiences. I've learned so much over the last few months working with Autism Bedfordshire in hearing people's views and just really tailoring some of my thought processes in terms of, well, oh yeah, I wouldn't have really seen it like that. I wouldn't have really thought about making changes in that way, but you can really understand what the benefits are. And putting people on a level playing field. This isn't about making a reasonable adjustment and giving people better treatment. This is just making services accessible for people in the same way as you and I without autism would expect. So what we're hoping with listening to people, we would be able to ensure that co-production and shaping services. Co-production is quite a term that we use a lot to think that we've had involvement, but actually sometimes that can be misleading as well. So we want people's involvement to shape services, and some of that's done with some of our procurement exercises that we're doing, which again, having done one recently, having had experts by experience on that group, it has taught me so much in the process itself. So we need to be listening to people. Alongside that, in order to improve the health inequalities that we face, we're ensuring health services need to know the patients. So that was our plea to GPs, making sure people are well coded, making sure that autism's on record so that we can ensure that reasonable adjustments are made and that people are familiar with it, their needs. And the workforce supporting people who are to be trained, as we mentioned about mandatory training, but I know that Autism Bedfordshire and other services are offering a range of provision now to ensure that people understand how to support an autistic person better. And likewise, we're developing lots of training with Health Education England and learning skills for care to ensure that services are better equipped going forward. And then making sure the pathways are there. I think ensuring that people can get the right services at the right time is really important. And we do concentrate a lot of this work around what's happened in mental health services, but it can be very easily replicated to ensure physical health is also right. Sorry. And this was just a bit of an oversight. We have a learning disability and autism regional program board, which has a health improvement group, and within that, around our group, there's a lot of stakeholders. But what we wanted to highlight was each of those systems, those 6 areas, are all represented in hearing the voices. So when Bex and Shana come to these meetings, they bring really valuable information. They all attend this meeting, and half the meeting is dedicated to listening to the voice of people. And it's so important that they hear this voice and then they take it away. And what I have been to is regional meetings where the feedback has been discussed, and local meetings where they've taken forward some of those views and made changes. And I'm sure Bex will go on to give you one example where this has been really positive in one of our areas. So I just wanted to give you a little bit of an overview of what's happening in our region, and hopefully some of those priorities will resonate with some of your own work. But likewise, if they're not happening yet, is to kind of be in contact with us and look at how we can make sure that the services are being worked on to improve access for autistic people. I think the next one, is any questions?
Oh, thank you so much, Tracy, especially with my trigger happy slide pressing. I think there was one question I spotted from Gemma. With the HEEGP training, will this also be available for GP pharmacists, as I'm starting to do stamp and medication reviews? Thanks.
Well, it's mandatory for all health and social care. So we're really hoping that once it's been piloted and we're completely happy with the outcomes of it, that regionally I would like to make sure that we see that it's rolled out appropriately for our region, and I would expect to see pharmacy included in that. I would really hope that can be championed by people. And I think that's the thing, is we've got to find champions. And I think the fact you're here today, you are the champions to be able to take this back to your workforce. And we link in with very much a lot of those regional leads. So our head of pharmacy for the region is very linked in with Stamp now, and we're looking at ways of ensuring that we can embed that within just general practice, because some of them become projects, and we don't want projects. We want this to be we just want this to be business as usual, that we would expect in the same way as anybody who wasn't autistic.
Thanks, Tracy. Oh, something else to win? Oh yes, no, Susan's just saying many autistic people also have sensory issues, difficulties too, which can have a significant impact, which is very true. Oh, thank you so much, Tracy. And it's been a great setup for the rest of this, so thank you.
Thanks, Bex.
Okay, so moving on. If I can get the slides to play ball. Yeah, I want to talk a little bit about the Hear Me, See Me campaign. And Tracy's kind of set the scene perfectly, because we've been talking about all of these initiatives and strategies. And this is one of the things that has come off of that. And so before I kind of delve into what we've been doing and where we've been getting our information for, I just thought I'd say why is this so important? And I think a lot of this is really common. A lot of this Tracy's touched on. 700,000 people in the UK are autistic, and that's who we know about, probably a lot more. 1 in every 100 people are autistic. I don't think that this I don't think it matters that we're restating this, because I think it really shows, right, that it doesn't just become a reasonable adjustment for one person because of something. Like, this is so many people, right? And this is environmental factors a lot of the time. I guess, as Susan was saying, that people have sensory issues and difficulties too, and so they're interacting with an environment that's really challenging for them. And actually, this is lots of people. This isn't a tiny kind of minority of people. So just wanted to kind of restate that. And some scary stats here. And again, Tracy's touched on this. These are all Autistica stats. But the fact that the average death is 16 years earlier than the general population is huge, absolutely huge. And a lot of this is due to having difficulty accessing services because of poor experiences or difficulty in accessing something in a way that feels okay for them. So I think something to kind of think on. Autistic adults without a learning disability are 9 times more likely to die from suicide, which is, yeah, it says it all, doesn't it? It's very shocking. And autistic adults with a learning disability are 40 times more likely to die prematurely. So starting on a really cheerful note, but I just wanted to kind of really reference why this is so important and why we're doing everything that we are doing, and why it's so amazing that so many of you have turned up today. I really am so grateful. And then I think a lot of this is not news and is not new to people, but we've got such a spread of people on this call. I just wanted to kind of have this documented. Obviously, the slides will be shared afterwards in the recording. But there's a really nice quote from Alexis Quinn. She's an autistic lady. She's a campaigner and activist. Our whole neurology, all our cognitive processes, our senses, the way messages are deciphered and sent from every part of our body to the cerebellum, the control center, are all shaped and formed by our autism. All of these different things. And it's really important to remember how individual this is for everyone. As you'll start to see when I start talking through some of the things that people have experienced, there's lots of kind of people presuming that autism looks or appears or is a certain way, and actually it's not necessarily that way. And I think it's really, really important that kind of there's a real thought about the individual, and about looking and seeing what is good for them and what is good for them specifically, and not just presuming things. Autism is a cognitive difference that affects how someone thinks and makes sense of the world. And there's a really nice quote later from someone who we talked to about, well, actually, it's how you make sense of the world and the environment that we've created as humans, right? And actually that environment might not be helpful for lots of the percentage of people. So how someone is thinking and making sense of the world, that's the difference. It's lifelong, not something that needs to be treated. It's a different way of looking at things. And then I just did a list of some of the things that might come up as challenges or things that autistic people struggle with. So social communication and interaction, repetitive and restrictive behaviour. This could be to kind of create a pattern, because if this really challenging world, right, that isn't so kind of conducive to how they see things, order and kind of repetition in that world can feel really helpful and help manage anxieties. Over or under sensitivity to light, sound, touch, or taste. And I think this is a really interesting point that will come up a lot as we talk through some of these slides, in terms of the types of environments that people are coming into contact with, right? Because hospitals, GP practices, there are times when light's needed, lots of light, right? And you guys probably know that a lot more than me. And so how can we kind of work together to kind of not make these environments so challenging, I guess, and not so difficult. Highly focused activities, hobbies, so a real special interest in something, which could be amazing and kind of really makes them feel pleasure and enjoyment from kind of pursuing that thing, but can have the kind of downside of meaning that other things are neglected and maybe not thinking so much about other things. Tracy mentioned mental health and anxiety and kind of the tricky, I guess, a grey area between them both. And this is a real thing. Again, lots and lots of autistic adults that we've talked to have anxiety in some form. They're trying to access a world that maybe is more difficult or not kind of meant to support them, and that can be really scary, and it could be that they have meltdowns and shutdowns. And I kind of put at the top, this might be one, some, or all. Everyone is an individual, and it doesn't just look like one thing. I feel like a stereotype that we were seeing when people were talking about things was that meltdowns, that's a kind of stereotype, and actually it might not show in the same way as it does from one person to the next, which makes it challenging, right? It's all challenging to be able to navigate. But I guess the more that you know, and the more that you're empowered, as well as the more that our adults are empowered to know their rights, as Tracy was saying, the more that we can help and the more that we can support in the best way. So the campaign itself. So over the last 4 months, we've been running workshops with our autistic adults. So kind of Autism Bedfordshire, we're typically Bedfordshire, starting in Bedfordshire and then quite quickly expanding Hertfordshire, going out to Essex, to Norfolk. These were all virtual workshops. And it was exactly as Tracy said, we wanted to hear experiences. We wanted to hear about what had gone well, what had not gone so well, what was difficult, what was challenging. But also we wanted to empower them with information and talk about reasonable adjustments and what could be available to them. Because actually being able to then go in somewhere and know your rights and say, well, actually I am entitled to something to help me kind of access this a little easier. And we've heard over 40 voices through this. And so you'll be hearing from some of those voices as we move through the presentation. As well as adults, we've also talked to parents and carers as well. So talking to kind of a range of people across the east of England. And we've created a web page with some resources to support and empower autistic adults around the Equalities Act, around reasonable adjustments. And so I just put a link, just in case anyone fancies looking. If you type in Hear Me, See Me, Autism Bedfordshire, you can get there as well through Google, I'm sure. But just in case anyone was interested, there might be some resources that they can share with people there. So I've kind of split some of the feedback that we've had from people into different kind of topic headers. So this first one is this kind of feeling of being dismissed, excluded, and misunderstood. And there's loads of text on this slide, right? Loads. And I'm probably not going to talk through each one of these, but the slides will be shared after if you do want to kind of go through it. But you can see, so this first one, almost everyone I've come into contact with in my surgery has a very limited understanding of what autism is. There's still such a stereotype of it being like Rain Man. And that was kind of echoed by people in various different forms. In kind of they expected me to talk in a particular way or to act in a particular way, or I felt like I was being patronised because I told them that I had autism, and immediately they presumed that I would be this way. And so that's a really, really big one. Someone saying here, because I present as neurotypical, which takes a lot of energy from me, people don't believe I have autism, and this is medical professionals. And it's really challenging, right? Because this is a big spread of different kind of challenges and needs. And so it can be really hard. And as we go on, I think there's a quote from someone saying they felt really bad for people in their GP practice because they would readily admit that they were not autism experts, and it's really challenging, right? Both ways. It's challenging not feeling like you know enough or have the right tools, but equally then on the other end of feeling like no one understands you and they don't know how to support you. I kept being told by someone my autism meant I had a learning disability, which made me feel really uncomfortable, as I'm high functioning and don't really consider my autism a learning disability. It felt like I was lying or accepting something that wasn't true. And I think that quote kind of leads into a kind of little thing about labels as well. We had lots of comments from people attending saying labels are really difficult. Some people don't like being called high functioning or low functioning because that insinuates they may need less support or more support, or it doesn't really kind of describe them, and maybe at some moments in time they can really engage and maybe other times they can't, and it's kind of popping them into one box. And so it's really useful to kind of talk to people and ask about how it is that they like to talk about things, how it is that they feel that they are. A misconception of autistic people not having sex, no thought for easy read formats around contraception, sexual health resources, or family planning. The person that I was talking to about this was saying that they felt like if someone who was not autistic went in for their checkup, they'd automatically be told about contraception or asked if they were having sex or asked if kind of they needed any support with things like that. And it felt like it just was not a question or a thought, because actually there's these other things. So I think just something interesting to think about, how kind of dealing with people. And then I said I wasn't going to read through all of these, and then I've immediately got sidetracked, of course, because they are great. So I sometimes use my son's blindness as a way to explain his behaviour, even though it's nothing to do with that. People are much more sympathetic to blindness than autism. My son has lots of challenges, but autism is always the last one I tell people about. People really discriminate when they hear autism. I think that's a really powerful one. I was talking to a mother whose son is blind and is autistic, and saying that it was the last thing that she told to people. She kind of used everything else, all of other conditions that might be there, because people were immediately more sympathetic. And so I guess it's useful to think about in your own roles, right? And in your own work, what's your preconception? Because we all have preconceptions from different experiences that we've had. And actually thinking about that, it's really sad, right? That she can't lead with the thing that is the challenging point, and go somewhere else instead. So healthcare support aligned with autism, and this is kind of talking to references to do with how people are accessing healthcare doesn't feel like the most safe or easy to access environment for autistic people. And we had a good few people talking about experience with hospitals, and talking about the difficulty with sensory things. There are bright lights everywhere. There's lots and lots and lots of people around, and actually being able to talk about that and mention what it is that makes them feel comfortable, they felt really challenging. A couple of people saying that when they did ask if they could be moved somewhere quieter, or if they could be in a space with less lights, or if a light could be switched off. Almost like a question about, oh, is that really what you need? Because they appeared, without wanting to use the term too much, high functioning, and appeared to be doing things really easily, and communicating well. And this kind of doubt of people not thinking that that's what needs to be helped to support. Yeah, here's the quote. I sometimes feel sorry for the staff in my surgery because they will openly say they're not an expert in autism, and more autism expertise would be so beneficial. And so I think why things like, hopefully today you'll feel like you get a little more, or there are little bits that you can take back with you. But it's becoming quite clear that this is a space that really needs to be considered and thought through. People in hospital didn't know what my sunflower lanyard meant, and for anyone who doesn't, hidden disability, and they just kept commenting on how pretty it was. So I guess like this understanding from people about that person found it really useful to wear a sunflower lanyard so that they didn't have to talk about autism every single time that they were talking to someone, and actually having that as a kind of introductory space. And we're going to talk a little more about reasonable adjustments in a bit, but reasonable adjustments are never offered. So it makes you feel like a problem or being difficult asking for them. And then it might not necessarily be the same. And let's face it, there's not always the ability to be able to do exactly what would make people feel the most comfortable, right? Resources are tight, space is tight, and it's just sometimes not practical with what's going on. But actually, it's a really good point. They're never offered. It waits for someone to kind of feel the confidence to ask. And that's obviously why we're doing lots of work in helping people feel more empowered and know their rights to be able to ask. But is there a way that you could ask? You could talk to people and say, well, actually, I know that you're autistic. Is there anything that would make you feel better? Maybe giving a list is sometimes easier as well than having to kind of just think of things on the spot. And I think that was echoed somewhere else. There should be a clear, defined, accessible way to request adjustments for healthcare. And then this really lovely quote: environments are set up for 95% of people, but can feel hostile for my children or myself. And I think that's a really important thing to remember, is that sometimes when people are presenting with behaviours that might be different from what is seen, usually, it could be because this environment is feeling really scary, and actually supporting someone to make that environment feel less scary. And I just wanted to pop that quote on as well, which is from Autistica's site, saying 8 in 10 autistic people experience the sensory world differently, and so it is more intense, right? The intensity is heightened, and so actually considering that's a lot of people when you think about the figures of what, at least 700,000 people in the UK, 1 in 100 people. It's a lot of people. And then mental health and autism, there was lots and lots of talk about this. And I know from talking to a couple of professionals so far as well that I think you guys have got lots to say about this as well. And it's really difficult to navigate. I guess the main points that were kind of being talked about was the idea of primary diagnosis and secondary diagnosis, and then potentially not being able to access all the support in relevant areas. And I think that's really, it's really important. I think I've got a quote, oh no, it's on here, isn't it? 7 in 10, more than 7 in 10 people, autistic people, have a mental health problem. And this could come from many years of trying to navigate this world in a different way. It could also just be a kind of separate piece of the puzzle, but why should their treatment be left because they fit into one box and not necessarily another? It's really, really tough. There was a couple of people talking about CBT specifically, and children being approved, finding it really difficult to engage with CBT because there's a struggle to connect with emotions and to use emotions for a lot of autistic people, and then that becomes really challenging. And so when that didn't work, he was seen as declining treatment, and now we don't have anything. We're not offered anything else. That's it. You've ticked the box of your sessions. And so I think there's some serious work to be done in this space of people feeling like individuals, and like these different parts are a puzzle, putting them together. It's not just you're in this side of things and now you're in this side of things. I think equally, kind of when talking about the difference of being labelled and put in different boxes, learning disabilities is another one. We kind of heard on a previous slide that some people don't necessarily associate themselves as having a learning disability when they're autistic. And because at the moment a lot of the support for autism is under that learning disability banner, if you're going into somewhere, you're not automatically looking in the right space to find the support for you. So yeah, it's a lot, right? This is a lot. It's a lot of like quite hard-hitting stuff, but I think really important to kind of think about and learn about. I want to move on to some kind of more actionable things and some more proactive things that we could do. But I just want to double check. Okay. Yes. Lots of things happening in here. Okay. Yes, Karen, you're so right. Really badly worded on that slide of highly focused, framed as challenging. It was just in the kind of realm, but you're very right. I did not word that well. Great. Okay. I'm going to keep going because we've got lots to go, but it looks like some great things are happening in the chat. Okay. Beauty of two screens, right? I wanted to briefly reconnect with reasonable adjustments, because again, we've got lots of people from lots of different spaces. What does this mean? We keep referring back to reasonable adjustments. People with a learning disability can have a poorer experience and outcomes when accessing healthcare. That's no surprise from what you've already heard. Equality Act require that NHS trusts and social care providers must make reasonable adjustments to remove any barriers, physical or otherwise, that could make it difficult for people to use their services or prevent them from using them altogether. These vary from person to person. And so without kind of staying on this for too long, I just wanted to give you some examples of these three different categories. So kind of the different options of where things could sit, change to the way things are done. So this could be something like a longer appointment time, if it might take you longer to process something, and actually getting that appointment time longer so that you've got the ability to be there to talk through everything that you want to talk to and have time to process and ask any questions that you have. Providing extra aids or services. So this could be things like a quieter waiting room, or allowing someone to kind of sit in their car in the car park until their appointment time, so that they don't have to be in a really busy, loud environment, as waiting rooms quite often are, and can be really stressful. Or providing easy read documents or videos, especially if kind of you're in a practice or a hospital where things are changing and there's new departments opening up. Can you signpost that to people ahead of their appointments, show them where to go using videos or easy read documents? And then changing a physical feature is things like a ticking clock. So if you went into a little room for your appointment and there is a ticking clock, that sound can be incredibly intense if sensory affects you a lot more, right? And can you just put that clock in a drawer or outside of the room for the duration of that appointment, something like that. So those are the different categories of reasonable adjustments. But I wanted you to hear from some of our workshop attendees, of which Karen is one. So it's lovely that you've joined us here today as well, Karen. Let me know if you can't hear any sound, because I'll just have to jump out. But hopefully this will run smoothly.
Hi, I'm Karen and I'm autistic and ADHD, and this video lists some reasonable adjustments that can help me in environments like the doctor's, dentist, hospital, etc. So, for example, be patient and friendly, smile and use my name. Acknowledge that if I'm finding it hard to engage, that the environment or delivery or connection with you is the problem, and this needs, rather than seeing me as a problem that needs to change. Be aware that I have a strong inner critic, so positive feedback is really important to help balance this out. Answer the questions I ask rather than the reason you think I'm asking the question. Open the discussion about reasonable adjustments with me rather than me having to do so with you. If I say that I have trouble completing forms, then please don't give me a form to complete in order to access a service or support. Offer alternative methods of booking and changing appointments if your usual practice is a barrier to me. Listen to what I am saying, even if the way I'm saying it feels confusing to you. Offer me a longer appointment so I have more time to process any information, manage my anxiety comfortably, and communicate. Give me a video showing me where I need to go when I get to the hospital, including the kinds of people that I will be speaking to. Talk me through every step of my procedure before it happens. Ask my permission to do something to me. Don't ambush me thinking that you are helping me to get on with it. Acknowledge that I may have a different pain threshold or respond to anaesthetic differently to others. Let me wait in a quieter area or outside and phone me when it's my turn.
Check out our preferred communication style, as talking with professionals can be very difficult. I often fail to get across what I want to say. Writing or using AAC can make it a lot easier.
Hi, I'm Shiloh, and I find it useful when I go to appointments when the person allows me the time to process the information that they're giving me, and they give me time to ask questions as well. I also find it useful to be able to have my headphones on, especially if it's in an environment which is particularly loud, or if there's lots of background noises like beeping and things like that, because then it builds up. So if I have my headphones on, it makes it easier to be able to engage. I also find it useful. I find it useful when afterwards I'm able to either get a report of what was said, or we go back through what was said, so that I am able to understand and process further what I was told, because sometimes there's so much information given and so much information I have to give. I'm not always taking the information in, and I find when I walk away from the appointment, sometimes I can't remember. So if I'm able to have a report, or if I'm able to at that end be able to either ask questions or go back through step by step what we have done, and that goes into the other point where I find it easier when it's specific, like if there's a set of instructions that need to be said to me, that it's broken down, and we don't talk about a load of different topics at once, because sometimes that can be very overwhelming.
My name's Philip and I'm an autistic adult, and today I'm going to share 3 things that I wish the NHS would do more of to make things a little bit more accommodating for people like myself. 1, easy to read format with things like letters, correspondence, information regarding surgeries or procedures, and booklets that may be useful to me as part of my health plan. 2, processing time to help me with my autism. When I'm in a situation where I'm in a room with a specialist or a GP or a nurse, sometimes my brain will go completely blank and I can't process anything you've just said to me. 3, things regarding correspondences. So ideally this would be great in terms of estimated timelines. So for example, if I went to a surgery, it'd be nice to know roughly how long to wait for my results.
My biggest concern at the moment in accessing medical services through the NHS and through private services is that since July 2020, it has been assumed, or an assumption, that a person accessing these services will cover their nose and mouth in indoor spaces and some outdoor sectors as well. And this has caused me a great deal of stress due to firstly the autism spectrum condition, but also a physical problem I have, the result of an accident where I can't walk properly any longer and become very tired very quickly as a result of that. This led me to contact somebody who got a letter for me last October from the Department of Health and Social Care, which I'd just like to read the lines from it, where it says, some people are exempt from wearing a face covering, including children under the age of 11 and those unable to wear them due to health, age, equality or disability reasons. People do not need to prove they are exempt and they should not be challenged about this. Therefore, Mr. Snowball should not feel uncomfortable to go about his normal routine, and nobody should feel intimidated to going about their normal business as this letter states.
Please believe us when we say something is difficult to do. Professionals regularly downplay my difficulties or don't believe me. This in turn makes my mental health issues far worse.
Okay, so lots there, and kind of completely different perspectives for things as well. And I think that's done a nice job of showing the individual, right? There is completely different things that each of those people wanted, but there were some similarities, right? And things that kind of were being said again and again. And I wanted, well, actually, especially as Karen's on here, I want to say a massive thank you, because I know how hard it was for some of those people to film those, and I think they've been really useful, and I hope that you've all found them useful. But big thank you, Karen, and anyone else who is on here who gave up their time to do that, because yeah, so useful. I wanted to also kind of carry through some other thoughts from people in the sessions, so not just those who went on video. Having somewhere quiet to go in hospital when I'm overwhelmed and have a meltdown. There were lots of comments about getting COVID vaccinations and some really good reasonable adjustments that happened in various places, kind of talking about specific spaces for people to go to with soft lights and no sound, and everyone spoke quietly, kind of making sure that people know the name of your son. But this is an interesting one, this middle one, because this is the mother really taking on that responsibility, right, for being advocate for her son and phoning in advance and talking about what would make him comfortable. But actually it shows what a difference it makes. But it's also worth recognising that not everyone has that, and not everyone has that kind of proactive someone who is asking. And it was really interesting, lots of the parent-carer discussions. There were a few autistic adults who had autistic children, and they were saying they found it so much easier to go into a hospital, to go into a GP practice and say, this is what my son or daughter needs, versus ask for themselves. And how much easier it is to fight for a child rather than actually what they need. So yeah, I guess again, it's that kind of empowerment to let people know what they're entitled to. And someone saying lockdown has made things easier. Maybe it should be a reasonable adjustment to keep some appointments online. We've had a kind of mixed bag of people saying, well, I really want things to kind of be like they were, but actually a fair few people saying, well, I much prefer not having to go in and wait in the waiting room and manage that difficult environment. But actually having appointments online has been really good. And I mentioned there too a dentist service that was great and gave longer appointments. I think this person in particular was talking about previous appointments before the one where there was a procedure needed to kind of get used to everything, to talk things through, and that was incredibly helpful. So what can you do? I've put down a couple of thoughts here. Obviously, there is loads. There's lots and lots of stuff, but I think that these are some things that you can not just take back on a personal note, but maybe talk to other colleagues about as well. Surprises. So surprises are big. We've talked about kind of there's in that some autistic people like routine and structure, and surprises could be something like a different entrance to a hospital or doctor's surgery, something changing, a different way of moving through something. So whether there's suddenly a sign-in pad as an iPad versus going up and talking to someone, something changes. So kind of recognizing that when things do change, what an impact that can have on people, and trying to give pre-warning to things. This is going to happen when you get here. These are the people that you're going to talk to. This is the process for things. Don't touch without consent. This felt like a funny one to put down because, like, surely this is standard, right? And this is, but I guess it's more the thought of making sure that you're talking through what you're doing, and that you're really being upfront and open about what's going to happen. Slowing it down in general, I think, is a really good place to start. Making sure that there's time to process, and that there's time to acknowledge what you've said, then kind of understand, and then go through whatever it is that's happening. Talk through the different steps, kind of give any resources that are needed about what's going to happen. Create a calm, quiet environment as much as possible. I know this is hard, especially in kind of the workplaces that a lot of you guys are in, but as much as possible, think about that environment, and I guess recognise if someone feels uncomfortable in that environment, and offering some sort of option to kind of change it up, whether that is something from as small as removing a ticking clock to moving into a separate room to going outside, thinking about that. And explain first and then do. So talk through things, give as much information first, and this could be prior to appointments, much in advance, and then moving through. And then there were kind of 3 top takeaways that I was like, if I want you to kind of go away with anything, or like think about how things could change. Individual needs for each person. Tracy's talked about flagging, and how that's kind of starting to make way into different practices and spaces across the east of England. But as much as possible, then using this, thinking about, rather than kind of flagging someone as autistic, what does that mean for that person? What is a reasonable adjustment that that person would benefit from? What is a way to support that person? Taking the time to understand that person. Lots and lots of really positive feedback came from people talking about GPs that they've known for ages and that they see regularly, or a nurse that they know really well. And so obviously it's easier in that respect to kind of understand a person, and sometimes we don't have that long, but really taking that time to kind of see that person as an individual. The health passport, I just wanted to pop a link here in case people didn't know about the autistic health passport specifically, because this has got lots of really nice spaces in for talking about special interests, and kind of for them to fill out lots and lots of different things. It's really exhausting. A lot of feedback came in that it's really, really exhausting to have to explain to absolutely everyone exactly what you need and want all the time. And so we're encouraging and have been talking to people who find this challenging to fill in one of these and present it. So kind of knowing for you guys as well that it's out there, that's there, there's the link. And so if you do have anyone who seems to be really struggling to get across what they need and would like every time, maybe suggesting one of these. And equally, if someone talks about one of these, knowing that it's important to take a look, and it might really, really help then that relationship and that appointment move forward. And then empowering people to communicate. Karen talked about video walkthroughs of locations on the video, and like providing as many options, I guess, for communication as possible. I know it's sometimes difficult, and there's lots and lots of kind of digital and technological factors that feed into this, right, and how we can communicate. But like if there are options for texts, for calls, for in person, for online. It just means that hopefully there's an opportunity for something that feels more comfortable. Lots and lots of feedback was coming through that telephone is really difficult, and people struggle to process and to ask the right questions and to be able to engage on a phone call. And so maybe just thinking about it, if that's the only option that where you work offers, thinking about how else you can change things up, or if there is something else that can be used instead. Okay, what time are we on? I'm wondering whether to give a 5-minute rest break for everybody, because I know that there's been so much talking, and the opportunity for me to have a look through some of these questions and for anyone else to pop in anything before we hear from Sharon. So if I give you 5 minutes until 11 minutes past 3, is that okay for everyone? I hope so, because we've still got a fair bit to crack through. It's so lovely to see so many of you on, and I hope things, I hope you're getting some useful stuff from here. What we've got next up after this kind of short break is Sharon talking about her perspective, and you can see Sharon there with her son Miles. And then we're going to hear from Colin and Erica, who are actually working, trying to change things and moving things forward within the NHS. So please come back and go and grab a drink, some water or something, and we'll be back on at 11 minutes past 3. Okay, he's starting to get people back. And Sharon, have I got you? You might need to unmute yourself. I've unmuted you this end, I think.
Yeah, I'm unmuted.
Awesome, fab. Hi Sharon, how you doing? Okay, so I'd love you all to hear from Sharon, who speaks so eloquently about her and Miles's experience accessing services. And actually, I might pop this screen down for a bit and just bring you up on screen, Sharon, if that's all right. Let me find you, if I can pin you so that people can see your face, if that's okay with you. Yes, there we go, fab. Okay. Yeah, so I'd love you to talk to us about Miles's diagnosis and when he was diagnosed and what led to it.
So Miles was finally diagnosed at 18, had had an EHCP from entering, well, it didn't start as soon as he started school, but the EHCP process commenced from primary year, reception year, so the first year of primary school, and he had an EHCP throughout. Due to the lack of appropriate support at 18, in actual fact, prior to him turning 18, he just turned 18 when we got the assessment because I was pushing so much. But just after he turned 18, we finally got him reassessed and diagnosed. We had a 2-year hiatus of no support in any way, shape or form, because at 16 he was discharged from paediatrics. Edwin Lobo is the community team in Luton, and he was discharged from them at 16. And I was told that he had to access adult services. They couldn't touch him, not till he was 18, because they're legally not allowed. And hence why I pushed for him to be seen as soon as he turned 18, because he was without any support that was appropriate for his needs. He had his EHCP, but it wasn't really supporting him adequately, and I knew this. I mean, I'm not an expert on autism, but I'm an expert on my son, and I've done a lot of research. With the appropriate diagnosis, Miles was able to access specific autistic support. He was referred to autism beds, and the impact on his education, his mental health, in so many areas has changed positively because of the diagnosis. So yeah, diagnosis was late, but once it arrived, hugely beneficial.
And how was that process? Because you mentioned that it was a long process. How was it navigating that as Miles's mum, trying to kind of
frustrating, because I'm not a subject matter on autism, although I probably am on Miles's type of autistic needs. I couldn't understand how something we could see so glaringly obvious, how clinicians, educational specialists couldn't see what I was seeing. Miles was diagnosed 2 points short of having a learning disability, and that's how they were treating him. They treated him like he had global development delay. I'm not saying that he doesn't have some learning difficulties, but Miles has done BTECs, level 2 in baking, level 2 in catering. He's doing a teacher's assistant role at level 2 at the moment. You know, he has ability. He is not learning disabled. Yeah, frustration is probably the biggest thing, and just a lack of all that lost time that could have been channeled in supporting him to his bespoke needs. Yeah, it's probably my biggest things.
Yeah, really frustrating. Once he was then diagnosed, was there clear signposting? You obviously mentioned autism beds a little bit, but what then kind of happened post diagnosis?
As soon as he turned 18, Twinwoods were amazing. They are based out near Bedford, and they are a learning disabled specialist. And because Miles was 2 points shy of being learning disabled as far as we knew, they were able to accommodate seeing him and getting him reassessed. And they were very good at signposting what was available, you know, college help and like specific courses for him to help with his self-esteem. But I have to say, Autism Bedfordshire, their involvement, and particularly I've got to give a shout out to Shana. I don't know if Shana's on board. Shana, oh, I see you. I see you. Shana was monumental in helping Miles. At 16, Miles was a very broken young man for a plethora of reasons. Autism, having some form of neurodiversity, makes it very hard for you to process the world. And Shana shone a light. I'm not going to get emotional. She shone a light, and it was night and day for us. It was night and day. I had a young man that didn't want to be here. It was that bad for him. He didn't want to be in this world. He wanted to be gone. And Shana came along and changed that. Thank you, Shana.
Oh, Sharon, thank you so much for being so open and honest. Oh gosh, I'm so sorry because I've got a couple more questions if you're okay to continue.
Yeah, no, I'm fine.
Yeah, we've talked a little bit already on today's call about autistic adults being statistically more likely to experience mental health issues. And I just wanted to talk a bit about yours and Mars's experience about accessing mental health services.
So Miles was 7 when he first talked about killing himself. And we lived in Hillingdon, and the CAMH offer was useless. It was it wasn't just the fact that it didn't support, it actually seemed to make him worse. And that's the reoccurring theme throughout his mental health support throughout pediatrics and adulthood until at 17 he was diagnosed with some form of depression, and Miles is now 22. So we're talking a fair old piece of time, 15 years. In 2019, I said, enough. I refuse point blank to lead my son into a room where people talk at him, where they ask a myriad of questions in a way he can't process. You want to do CBT or some other, recognize how you're feeling. And once you're feeling like that, these are the steps you put in place. Miles doesn't recognize how he's feeling to put the things in place in the first, like you might as well talk to him in Arabic or Swahili or French or some other foreign language. He doesn't understand it. So I'd had enough. And I said, no more. I want someone that is autistic specific to support my son. I need someone that's got autistic specific either training or hands-on experience. I need that for my child. He deserves it. He's had too many years of substandard, not substandard for the general population, substandard for him. And I basically interviewed a load of community health professionals. They would phone me up and say, "Hi Sharon, my name is, I don't know, Dan, and I'm a psychologist or I'm a psychiatrist. I have an autistic background." And I would interview them, and I would find out, no, you don't. You did a little bit one time when you was doing your doctorate or something. You are not a specialist. So finally, after they had nowhere else to go, we got funding for Miles, and he now sees a lady called Elaine Nicholson. She works for Action for Asperger's, and she's based in Northampton. And once every 3 to 4 weeks, we trot Miles up to her. She has been amazing to finally have someone that when you go into a room doesn't make him feel even more inadequate, doesn't reinforce all those negative feelings he has about himself. Someone that actually understands how he processes the world and can help him work out how he needs to process the world for him, and how he doesn't need to feel bad about processing it the way he does because it's different to everybody else. Having that has been amazing. Miles has, like other autistic people, Miles just doesn't have mental health problems. Miles has got colitis and arthritis and fibromyalgia and potentially a thyroid issue. You know, we've got a young man that's got lots of stuff that he has to cope with, and Elaine helps him process the world. It's early days. She's been involved in his life now, coming up to the first year, and we've got a lot of unpicking of bad experiences to go through. But she's had great inroads with him, and I'm excited about what she can bring to him going forward. There's definitely a change in how he is. So yeah, the journey has been awful up until a year ago, because he has a very bullshy mum that's managed to get extra funding for him, which isn't the usual thing. It's not what most people with autism or their parents are able to do. But I wasn't taking no for an answer. And we shouldn't have to do this. I shouldn't have to interview professionals to find out whether you truly do have the appropriate qualities to support my child. I shouldn't have to do that. You should have the right person for the job. I don't want anyone to do anything extraordinary. I just want someone to do their job with my son. That's all.
Oh, Sharon, I can see lots of really lovely comments coming through to you as well, from saying how much your words are touching them as well. So yeah, thank you so much. I still have a couple more, because I'm just wondering, we have such a wealth of different workers within NHS, within different healthcare services here. If you could suggest 3 things to them that would make Miles's like interaction with the services easier, better, what would those be?
I think the first one would be diagnosed better. Miles was clearly, Miles is profoundly autistic. If he'd been diagnosed better, then half of what he's experienced would never have occurred in the first place. So I think the first thing is diagnose better, and create neurodiversity awareness within the NHS. For the first time, so my son has complex health needs. He's in hospital for various things all the time. We had our first clinic appointment where I came out and me and Miles were in shock, where the lady asked some questions, and it's a new rheumatologist. She asked some questions and then went, "Oh, excuse me, I'm so sorry, Miles. I've confused myself by asking all those questions all at once. Let me break that down." And she asked one question, very basic, and stopped and let Miles was. It was the first time I really heard him speak for himself. Usually he'll look at me and ask me to speak for him. He'll ask with his eyes. He doesn't ask with his voice. He won't speak at all. This was the first person that had actually asked Miles, well, sorry, or said to Miles, well, sorry, let me break that down for you. So this was, in all our journey, this is the first one that actually took time to accept that Miles was autistic and her approach needed to perhaps be a little bit different. So I think diagnose better, be neurodiverse aware, and with that awareness, understand the things that need to take place. So it's about being gentle, about being having empathy for how they may feel, just being in that clinical space, the smells, the sounds, the noises, all of that will be overwroughting that poor person, whether it's a pediatric patient or an elderly person that you would think would have learned tricks and traits to accommodate the world that this non-autistic world that we live in. But just have some real empathy for people. Not all autistic people have learning difficulties. Not, there's some real high functioning people out there that have autism. Don't go in there with a preconceived idea of what autism looks like, because autism looks different for everybody. I think probably that's my lot. There's probably 4 things.
Thank you. No, thank you so much, Sharon. I can't thank you enough. And like I said, there's lots of, I think there's someone asking who the lady is who you were saying was great with Miles, so you might want to contact.
It's Dr. Khan. She's a neuromatologist at Luton and Dunstable Hospital. And she was very nice.
Awesome, thank you. And thank you so much. Really, really appreciate your time, Sharon. Thank you.
Okay, thank you.
Okay. Oh gosh, I'm sure I'm not the only one moved by that. Yeah, the reason that that's at this place in the agenda, because as Colin has very much pointed out in the chat, and it's Colin and Erica who are up next, is that there's a long way to go, but there is stuff that is happening. And so I didn't want to leave you on a kind of, oh my gosh, all of what is kind of wrong with the world. So we're going to end on a more positive note. So let me share my screen again. And welcome Colin and Erica, who I hope are unmuted. Shout if you can. Okay, potentially you are not. Let me stop sharing for a second and try and find you. Are you labelled by your names? Let me make sure you are unmuted. I think I saw Colin. Still on mute. Let me get you off, Erica. Okay, I've allowed your mic, so you should be okay.
I'm in the room, I think.
Yes. Fab.
Hello.
Hello. Thank you so much for joining.
I don't think I'm labelled on here. I'm anonymous, but
I've got you.
Thank you for having us.
No worries.
Yeah, and dodgy photo. Not Eric, because obviously that I'm talking about mine. I hate having my photo taken.
Yeah, don't bring Erica down with you.
I mean, look at Erica, she's fabulous, but I didn't need like being in photos at my own wedding, so.
Well, thank you so much. I'm going to pop myself on mute and let you guys take it from here.
Okay, so are you going to move the slides along, Bex? Okay, so yeah, if you can, hopefully what you've got is what I've got in front of me, so if you can put the next one up. Yeah, so just, Sharon, tough act to follow, but lots of what you were talking about, I think for me and Erica, resonates really clearly. So just to give some, so this is on the slide, you can see that's, I think we've got half an hour, is that right, Bex? So this is what we were going to, again, it's difficult, like what do you talk about in that time, but this is what we were going to try and cover. So a little bit about, basically what our service is, what we do, but also how we're trying to help in terms of what this project's been about, trying to address some of the challenges in services. So we're going to talk about a few slides each, but just to give some context, I'm a learning disability nurse, so what Sharon was talking about with the distinction between learning disabilities and learning difficulties, and Erica works in LD service as well as our team, but she'll introduce herself. yes, really familiar with that. As there's the confusion that those terms can cause for clinicians, particularly, or in terms of gatekeeping to access different services and things. It can be a minefield. And particularly, I mean, we recognise how complex that can be, and we work in the services, and we know what some of those barriers are, or some of the service criteria are. So for people who aren't on the inside of that, it can be even harder, and I understand, incredibly frustrating. And even with that, we get a lot of inquiries and referrals to our team that is stuff we just don't deal with, even if we'd like to. So it can be, from a service perspective, it can be very complex, and and then even if you think you're talking to the right people, trying to get them to listen or refer on to the right place or recognise. Yes, I mean, lots of that makes sense. I mean, obviously, we work with adults, but we get referrals, people just turning 18, and often the backstory is very familiar to what Sharon was describing, and we get all sorts of other stuff. So if you can go on to the next slide, Bex. So yeah, just to give very briefly, just an outline of what our service is, and then we'll talk more about actually some of the other stuff around that. Yeah, but basically, we're a diagnostic service for adults. So we were commissioned and started. I helped set the service up, and still haven't left. In 2013, and initially I was seconded from the team, LD team I was working in, as a temporary thing, and then I just never went back. So stuck with me now. And for me, even as an LD nurse, and I've done training. I've got a master's in autism subsequently, so I've got some training and stuff. But even for that, massive learning curve for me over the years. So to work with people who are autistic, or for us might be autistic, people who generally come through. But for me, that was a massive learning curve, and particularly people who are higher functioning, just the diversity, how that can present, and all the other stuff that can go with it for people. Yes, but so to give a sense of the service, we're a very small team, as most specialist services are, to be honest, which is why there's normally a waiting list. We cover the whole of Luton and Bedfordshire, into bits of Hertfordshire, depending on where people's GPs are, based on commissioners. So we are primarily a diagnostic service, but we do a bit of short-term follow-up as well. Erica does a lot of that. She can chat a little bit about some of what she does. But there is a limit on that. We have to limit that because we are a diagnostic service first and foremost. But within that, then we try and signpost people on or connect people up to other services for support. So we work a lot with Shana and Autism Beds. And Shana knows how much me and Erica can talk. So you're brave trying to give us half an hour. But yeah, so we've really developed a really strong mix of Autism Beds as our service has developed. But yeah, from the outset, we've always tried to link in with other services within ELF, East London Foundation Trust, so the local NHS. When we first started with Recept, it was a different NHS trust who run our service. So, but it's always been our service, just like different letterhead, essentially. Over time, but within that, we've always tried to support colleagues in mental health teams and other areas who don't know a lot about autism. We've got this person, we're struggling with them. How do we work with them, because we don't know much about autism? In the early days, it was sort of like, we've got this person who's autistic, they're your patient, and I was like, no, they're not. They got mental health needs. I have to say that's moved on a lot, particularly since ELF took over services. But yeah, as I say, long way to go. But again, we'll talk about some of what it has been changing and what we're involved in. But yeah, I've seen that from when the team first started. I used to go out to team meetings, mental health teams, and just say, "We're here now. This is what we do. This is what we don't do." And we got a lot of referrals initially that shouldn't have been coming to us, literally because it mentioned the A word, autism, Asperger's, whatever. So I used to do a lot of firefighting and just pushing things back to mental health teams and saying, "No, this is your job, but I can help you with it." So again, briefly, referral criteria, people 18 plus. I mean, we've taken some people who are 17, going through transition, but we haven't got an upper age limit. So yeah, we've seen people from just turning 18 up to be in their 70s and everything in between. So yes, for us, there are no restrictions on the person's level of cognitive functioning. So that whole thing about learning disabilities, learning difficulties. We've had people who are absolute boffins and much cleverer than I am. So in terms of that, if the query is this person autistic, they get referred to us. We have to look at the referral to make sure that there's enough rationale for us to offer an assessment and get them on the waiting list, but we're still trying to strike a balance with that between being accessible and not taking people down the wrong path. We don't expect GPs or anyone else to be experts on autism, but they need to have enough indication of why they're referring. So we do reject some referrals if they're just not indicating that they've got adequate autistic traits, or we will try and make contact and just try and fill in some of the gaps if we're looking at a referral. But yes, we do try and be accessible if that query's been raised and exploring why it's been raised. So we still get a lot of referrals to people who are autistic and need asking for specialist therapy or they're in crisis, and we have to decline those. We do try and refer them onto the right service or signpost people, or again, we get a lot of referrals from mental health teams, and we try and get back in touch with them and just say this person needs your help. It's their mental health which is the issue. We can advise you about how to work with them around the autism side of things. But obviously, the person needs to agree to being assessed. We can't drag people off the street, virtually or otherwise, to say you need to have an assessment because someone else thinks you're autistic. If the person doesn't agree, and we have people who agree to an assessment even if they don't think it themselves, but their family does, or a professional's raised it as a query for them. And sometimes it's the person very much who thinks they might be autistic and they want to get that answer or that clarity. So yeah, the range of queries on why it gets raised or when it gets raised for us varies enormously. I can see there's some questions popping up. So Bex, can you see those as well? Yeah, I'll try and have a look at those and answer some of those as we go through. So let's have a quick look before we change. So yeah, so just at the bottom there's the team as well. So there's myself. I do some of the clinical work and I'm also the team manager, so my time split. Erica is our occupational therapist and she's brilliant. So she tends to do a lot of the post-diagnostic stuff, particularly for people around sensory integration or issues in the workplace, so particularly things which tap into her OT skills. So Erica's part-time for us, 2 long days a week. I'm full-time. We have a psychiatrist who, again, does sessions for us, but he's not full-time. We have 2 support workers, one of whom does 3 days a week and one is full-time. And we have other doctors dip in to help us do diagnostic assessments. So it's a very small team, very big demand. So yeah, in terms of getting the right support, people contact us even just asking for advice. So we're happy to give people advice or to signpost people to where they can get support. Often that's autism bedroom, people who've got a diagnosis. Waiting list for us, before the pandemic, it was 10 months to a year for an appointment. That's varied a lot during the pandemic because we had to adapt how we do assessments a lot, and so at the minute it really fluctuates. But there's always been a waiting list because we're a specialist service and there's a small resource and big demand. But yeah, any referral that comes in, we screen them. We have a weekly team meeting, so we always screen any referrals that come in preparation for the team meeting. So if it's a bit sketchy, but we think there's enough, then we might contact and ask for more information. If it's accepted, we send out some screening questionnaires initially to get the process started. So within that, there are lots of different questionnaires get used by different teams. So these are the ones that we use. Couple of which ones that we developed ourselves. So the one asking for developmental history, ideally from parents if they're available, and the sensory checklist, which is one that Erica's helped develop for our team. So we try and get a lot of information before we even see someone to try and get have some information up front that we can draw on as part of an assessment. But if we decline a referral, then we will write back and we'll give some information on why we haven't accepted a referral, and we'll try and give signposting advice and recommendations on what the presenting issues are that the referral's talking about. So even if people that we say, no, sorry, we can't offer you an appointment, we're still going to try and help. But normally that's then trying to people, sorry, this isn't for us, but this is where you could get support with this issue. So we still try and be helpful where we can. So the diagnostic assessment usually, when I say usual, this is before COVID, was typically always in 2 stages. So a person would normally meet one of our doctors, so a psychiatrist or a psychologist, again with training in autism ideally. Some of the psychiatrists who come through for us on a sessional basis, sometimes autism isn't their first or their core role, but they will have had some training with the other doctors in our service, so they shadow some appointments, have some training, so they have some idea what they're doing. But there might not be an autism specialist per se. But then what they will do, we use quite a structured assessment tool, so that does guide the doctors through what information we're looking for. And our psychologist is autism trained, so we do have those specialisms. But we always have encouraged involvement of family or other informants. So it's not just the individual trying to give us information. So we're trying to get someone else's perspective, but also the person can benefit from having that person to support them as well, if they're anxious being in an interview. But we just say we very much like, yeah, bring people with you. If you want to have a friend, a relative, whatever else, and they can, either, as well as support you, they can be involved in providing information. And then the second stage assessment is typically with myself, which is using the ADOS, which is, again, it's a well-established diagnostic tool for autism. It's used all over the place and has been for years. So I do a lot of those. Our psychologist sometimes does those if they're not doing the first stage appointments, but I do most of the ADOSs. For some people, Erica does a second stage assessment, or that's on the next slide. But we've adapted the process. But this is how we used to do things. So this was all like face to face. So then we would do a detailed report about the assessment, having discussed it in the team to get to an outcome. We then offer a person a follow-up appointment to answer any questions they've got about the report, the outcome of the assessment, try and give them appropriate advice and link them up to other services for support, depending on what they need. And then along came COVID. So if we could look at the next slide. So just go to some of the questions. How I subscribed to this service, massively, to be honest, is a short answer. We've obviously demand has ebbed and flowed over time, as so has capacity of the team. What doctors and that we've got available has fluctuated as well. But we've been doing some statistics looking back at the service since it started, and pretty much with the demand for the referrals is outstripping the capacity that we've had as an overall trend. So we are trying to put together a business case to expand the team if we can, or we know that's an issue. So we are trying to look at ways to try and manage that. I think Erica's put a comment in the chat as well. But that's one of the reasons why we try to be robust with new referrals coming in, so we can make sure they are appropriate. So if there's not enough rationale, we will send referrals back. I mean, we always say if you can get more information, refer to us again, but we try to make sure that people who we've taken on for an assessment actually do need an assessment, as much as we can tell. So people aren't waiting 10 months or whatever from the assessment. When to get that assessment, it's quite evident they're not autistic, and that appointments could have been used for someone else who needed it more. But it's not that straightforward by any means. But within the adaptive process, I think particularly we've become really aware of a lot of this about the quality of the information as much as about the process that you're using. So when the first lockdown started in March last year, we already had a lot of people booked up for face-to-face appointments. We had to cancel a lot of those because we were just told you've got to stop face-to-face appointments. It was I think about a week's notice. But we didn't want to, and some services I know did shut down completely. Staff are redeployed elsewhere in the NHS. We didn't have to do that, luckily, but that was always initially on the cards. It was a possibility. But instead we were able to we need to adapt our process so we can still do assessments. How can we do that? So I think the first couple of months of the first lockdown, we did loads of work scoping what we could do instead to make sure we could do assessments robustly, remotely in a COVID safe way. So what we'd introduced assessments like this on screen, so with the doctors doing a video interview. And again, we did a lot of scoping mail shots to people saying this is what we're looking at having to do in terms of assessments. Can you engage with this process? And we mapped out this is what we'll be doing. Can you engage with this? If not, you can wait for a face-to-face, but it's a longer wait. So a lot of people did sign up to yes, they could do a video assessment. And then we would send people out information on how that process was going to work, the technology that you would need, all that kind of groundwork stuff to get people then basically bums on seats, but like this. So we developed an alternative process, and then the stage 2 assessment, I couldn't do an ADOS with people sitting in a room together. For one thing, obviously, because you couldn't do face-to-face, and equally with an ADOS, you've got to be sitting quite close because you're doing some practical activities together. So I can observe how the person processes and problem solves and stuff. So it involves equipment as well. So there's the cleaning of stuff, the infection control side. So again, we couldn't do that face-to-face either. So we developed an alternative video interview, which used a lot of the concepts from the ADOS, but it was still done remotely, for people who could engage with that, which was most people, I think, who were waiting on the waiting list could do that if we outlined how we were going to do things differently. And again, with that, we encouraged family members to be involved as much as possible, at least in one of the appointments, so we could get another person's perspective. So we're trying to make sure that the assessment itself, in terms of the process, was still as reliable and valid as possible. So there was a lot more emphasis on actually gathering the right information rather than the process itself. Particularly the longer the lockdown went on and the pandemic went on, we become increasingly creative with what we were doing, how we were doing it. So yeah, so for some people, particularly then if there were tech problems, we would do some of the stuff over the phone. We would talk to relatives separately on the phone to gather information. We'd have conversations on email and all sorts of stuff. And I know Erica did some assessments, particularly between the lockdowns when you could do some seeing people, but with restrictions, Erica was doing assessments walking around parks in a village hall, and so we've got, okay, we need to do this, how can we do it, rather than, well, this is our process. Person-centered was like beyond, wasn't it, Erica? We just did all sorts we need to gather this information, let's look at different ways to do it. So it was very, very person-centered in the end. Again, still trying to make sure that the assessment was robust. We did lots of networking with other teams in exactly the same situations across the country, and everyone was doing something different. If they were still doing assessments to try and get around some of these difficulties. So there was a lot of, in a professional perspective, there was a lot of people sharing ideas and good practice and what was working, what wasn't working. So everyone was experimenting a bit, but still trying to make sure that they were doing a robust assessment. Because clinically, if we're going to give a diagnosis, we've got to make sure we're getting it right as much as possible. And there were still some people where we still weren't sure, and they then had to wait for another face-to-face, but we would be given as much feedback as we could about this is what we've got, this is what we need, or if we ruled out a diagnosis, why we felt that was. And there were some people who then said, well, I don't think you managed to do a good enough assessment on a video, I want a second opinion. So again, we did some of those as well, either again on a video, but trying to use a different approach, or different members of the team to gather information to cover gaps or where there were discrepancies, or then wait until we could see someone in person by whatever means to try and clarify what's come out of the initial assessment to review that. So again, all the way through, we've just been adapting, and we've relied a lot on feedback from people, what they found has worked, what hasn't worked, what can we adapt so we can do it better next time, or in the person's next appointment. So they've been very, very flexible. Yeah, and as I say, everything that we then brought back has been discussed by the team. So whatever information we have got and however we've got it, we've pulled the information together to get to a conclusion. So we try to make sure it's as robust as possible. Yeah, and within that, so I'm going to hand over to Erica. Within all that as well, we've liaised a lot with mental health teams, with people who are either working with people who are autistic or they're referring to us. So over to Erica.
Thank you, Colin. I'm just looking at all the wonderful questions people have. I'm really grateful that people are being interactive and asking questions, because this is what makes a good presentation, really, and an interactive one, especially in the last slot of the day. So thank you. I will try and answer some of them at the end as well. So and some of them
we go through, Erica, while you're talking.
Yeah, you can answer the one about the AQ and about the I'll briefly answer the one about the sensory integration questionnaire that I use. It's one that we kind of developed. I developed with my colleagues, really. It's a kind of a cross between a Winnie Dunn questionnaire and the adult sensory history. There isn't one that kind of fits perfectly to ask all the questions that I want to ask about the way people interpret the sensory information coming to them from the environment. So I've kind of developed my own one that hopefully opens up discussions with people. And sometimes it isn't following a questionnaire, sometimes it's open discussion about how people process the world, which can be completely different between one person to the next. within the autistic population and the general population. So it's really interesting being able to find out about how other people process the world. What am I talking about? So what can we do within ELFT? So we have been talking to mental health services, as Colin has been mentioning already. We talk to there's so many challenges that people face from a mental health perspective, and we know the statistics are really quite awful about people's mental health that have autism. But within autism, we want to make services accessible as possible. So sometimes people feel well supported by services, and we've had good feedback from people accessing the services that they need, but we've also heard lots and lots of stories that really shouldn't have happened, really. People not being heard, not being understood, people not accessing the services or being discharged from services that they should be able to access, that type of thing. So we're working hard to try and change things. Quite often people don't understand enough about autism, and so obviously training is so important, and how that can impact on somebody's mental health needs, because often they've got mental health needs and autism, and what comes first, and how can their autism be considered alongside their mental health needs, can be quite complex. People often mistake the autism traits as mental health, or the other way around. So it's quite important for people to have a good understanding about what autism is and how that impacts on mental health. And the way that people access the therapy is sometimes hard to engage with. So people might, the psychologist, psychiatrist, other clinician might need to adapt the way that they're supporting somebody so that they're able to engage with the process, that the therapeutic process that they're trying to provide. Reasonable adjustments often, well, sometimes not offered, or the person's not able to say themselves what they need. It quite often is a bit of both, really. People can't advocate for themselves, or maybe don't have a mum that's going to speak out for them and get them the right services that they need, but hopefully there's some other kind of advocates out there that can help support them, like at Autism Bedfordshire, get the right needs. Can I have the next slide, please? So the green light process was a 2-year kind of project led by the government to try and help professionals understand more about autism and learning disability. So it's not a new thing that we're trying to do. So we've been trying to kind of promote people's understanding in their mental health teams for quite a while now. But we are updating our training and trying to continue to provide up-to-date kind of community mental health team training, as well as inpatient training for those working with people. And we have made bespoke training packages for people, within their team, about how they can best adapt the way that they're working. For example, the Bedfordshire Wellbeing Service, our psychologists have done some work with how best the other psychologists in that team can adapt the way that they're working with people, so that they can be neurodiverse friendly, essentially, give people time to take in information and all of that. Our mental health colleagues are encouraged to contact us, and we do get regular daily phone calls, emails from people saying, I'm trying to support this person, can you help me? Have you got any ideas about how I can make things better for this person? Anything I can do to help them access our services. So we do have daily discussions with people, and Colin's provided the autism awareness training through the ELFT Recovery College, which was open to everybody as well, and the clinical support meetings that he does on a Wednesday morning for people who it's for professionals who are supporting people with autism through inpatient units. But we also we work closely with Autism Bedfordshire, who do provide an awful lot of support for our service users as well following diagnosis, and signposting advice for newly diagnosed individuals about autism related resources, pathways into mental health services, and working out exactly what they need. Sometimes that's a social needs assessment as well, working with other partners to try and work out how best they can be supported going forward. And everybody who accesses our service gets a post-diagnostic appointment with us. So it's everybody that, even if they don't have a diagnosis of autism, will still try and work out how best they can be supported and get them, get their individual needs met. So our emerging projects, adapted sensory one. Oh, sensory profile. Sorry, I'm just reading the questions. Yeah, no, it's one that the questionnaire that I use is one that I've developed with my colleagues to try and get all the right information out of people. It's one that I've adapted from other questionnaires that are out there that don't quite get all the information that I need. So I've kind of taken bits from different probably shouldn't. Yeah, it's not standardized, but it does have a lot of. It's better than just using one questionnaire that is standardized, I think, because it gets all the information that I need to kind of make a sensory integration hypothesis. So going forward, our service is reintroducing face-to-face appointments, but continuing to provide the option for video call assessments. And we've got the feedback. Initially, we sent out a questionnaire and we got loads of feedback about how people were finding the video calls, and actually quite a lot of the comments were positive. And I can sit in my own room and I don't have to go out, and I can engage with the assessment without feeling too. Sometimes it's more uncomfortable for them to come to a clinic appointment. But other people said, no, actually, I think it would be better to see someone face to face. So we get that. We got kind of mixed views, really. And some people didn't want to engage with the technology or were unable to engage with the technology. So we started at the face to face, but we remained quite flexible. And we're using a quality improvement project to try and reintroduce the face-to-face appointments and come up with other strategies as well, work out whether there's any other ways that we can use within the resources that we have to reduce our waiting times for appointments as well. So we're working collaboratively with the Autism Bedfordshire and Elford Recovery College to develop some new workshops. Quite exciting. These are only just hot off the press, really. New workshop for people waiting for a diagnosis assessment. So I think I saw a question in there about what support are you providing to people waiting for an appointment, and I think someone said that, didn't they? And actually that is what we're trying to develop with the Recovery College, and they're working with us to work out who would best, who needs that support and what should that support look like. And I think someone put a comment in there about maybe that should be peer support. So that's a really lovely comment and really, really good. And a lot of what the Recovery College does is work with people that have experts by help me, Colin, what are they called? Experts by experience. There we go. Experience. Yeah, people that have experienced themselves, the difficulties. Everyone's helping me there. Thank you. So yeah, no, it's very important to involve service users in any kind of projects to improve services, because obviously I'm not autistic. I don't know what it feels like, and I don't know what autistic, although I've seen lots and lots of different people with autism, it's really difficult to kind of understand exactly what they need without hearing it from them and themselves. So yes, good point, whoever that was. Collaborative work, yeah, so we've done that. Post-diagnostic, yeah, so we're working with Autism Bedfordshire to employ a new support worker to try and provide even more post-diagnostic support for people, because we understand that it's a very difficult kind of thing to be told that you're autistic, especially later in life, and often these people have a lot of needs and a lot of potential, really. Like you say, a lot of them maybe don't have learning difficulties or disabilities, and they do have a lot of kind of potential to achieve a lot in their life. So if we can work with them to get them on the way to working towards their goals, then that might be a really good thing. So that's what we've recently kind of advertised for a support worker to support people for a slightly longer period than we already do, to help them. Sorry, I'm rambling now. So yeah, we've got projects underway as well. There's been some funding agreed to improve one of the mental health inpatient units in Bedfordshire, and that will be implemented in the next financial year. So they're going to be adapting it to be more sensory friendly, essentially, and a better experience, hopefully, for those people who have to access, because obviously the main hope is that we can keep people out of hospitals, and provide them with the support that they need in the community. But there is some situations where that's not possible. So when they have to access an inpatient unit, making it a good experience for them, and so that, yeah, that unit will have people trained in autism, people trained in sensory integration, you know, people understanding the needs that this population have, so that they can hopefully make that experience a less traumatic one. Next slide, please. Oh, that's the end of the presentation. That's wonderful. Okay, shall I have a quick slide through all of these questions that have been appearing?
Yeah, sorry, was just unmuting myself. Managed to lose the thing. Yeah, we are running very very short on time, as I knew we would. So if you wouldn't mind going through the questions and replying to any now, but equally, if people want to keep on putting questions in, I'm going to take all of these afterwards. And if it's okay with you, Colin and Erica, might send some more your way. Is that right?
Yeah. Did you answer the AQ one, Colin?
Answer a couple while you've been talking, Erica. I know there's a few people asking for copies of some of our templates and stuff.
All right.
Awesome. Okay. We'll keep track of them. We've only got a couple more slides. I know that some of you will have to rush off to meetings already, so please do. And can I just say a massive thank you, Colin and Erica, as well, because as everyone can see by the amount of information there and things that they're doing, they are so busy. And so thank you so much for sparing a little bit of time. I know you've had to pop off meetings and manage that, so I really, really appreciate it. Thank you.
Yeah, I mean, I'll go back through the chat, and yeah, people who've asked for copies of the documents, I'll send those, and I'll give you a bit of blurb, particularly with the ADOS, how I've been using that. Because even virtual, I've started doing a few face-to-face. I'm not doing probably what you might consider a traditional ADOS. So again, that's just me. But again, I think there's a lot more emphasis on gathering information rather than just following a process more rigidly. But yeah, I'm happy to chat. I'll go through the chat and I'll send some of those bits. And
thank you so much.
Thank you, everyone. Yeah, sorry I missed the start of it, but it looked great from the bit I did see. So
that's all right. You could, well, in your very busy schedule, you may not want to, but there will be a recording. Just in case. Yeah, I just wanted to kind of finish up. I'm going to hand over to the Director of Adult Services at Autism Beds, Shana, in a second. But I just wanted to talk about what's next. I'm really interested in the middle point on this slide the most. I know surveys are a pain in the bum. I promise this one is super short. I'm really interested, because this workshop spiraled and we had so many people, were there any bits that you want us to go more in depth on? Were there any things that you would find really useful that weren't covered today? Was there anything in particular that you want to see more of? And I would love that so much if you could fill in the survey. Once Shana starts talking, I'll share that into the chat, the link, so that you can see it there as well. And we're thinking about an advocacy workshop, but there's the opportunity to kind of talk about if you're interested in that in the survey. I'm just going to pass over to Shana for a final thank you and send off.
Thank you so much. Firstly, I just want to thank all of you so much for coming today. When we started on this journey with Tracy, oh gosh, 10 months ago, I didn't ever imagine that we would have 170 people sat in a presentation that we put together with support from lots of people. So I just really want to thank you. And what it really reminds me of is how much people do want to help and support out there. So please do get in contact with myself or Bex or Colin or Erica. Apologies, Colin and Erica, but I'm signing you up. If there is anything that you want to know, you feel that can be supported. Bex, and I love the fact that you put in Bedfordshire, Hertfordshire, Milton Keynes. What some people don't know is that we are moving into Hertfordshire. There'll be correspondence and communications going out, but I'm really, really quite excited about the launch of the service in a few weeks' time. We do a lot of work around post-diagnostics and support that we can deliver that support elsewhere. So if people want to have a conversation with us about what post-diagnostic support looks like, and what information or what should be delivered, I guess, in post-diagnostic support, please do get in contact with us. We're happy to discuss that further. But also, I appreciate lots of you are after lots of training. So if you could do Bex's questionnaire, that'd be fantastic. One of the things that we would really like to look at is helping you
help your patients or your members, depending on how you refer to them, help them advocate in the settings when they're with you. And that's a sort of workshop that we're really passionate about delivering in a couple of months' time. So if there is anything that we can do also to help you, I appreciate there's lots of different questions coming through about different areas. I can probably answer a lot of those. So I've given out my email address at the start. So if anyone does want to get in contact, please do. And again, I just really want to thank you all so much for attending today. It's incredible to see how many people are here, and you know how we can all work together to change things for autistic people and help them live the life they should be living.
Yes, thank you so much, Shana, and thank you so much for you, Shana. I've seen you popping up answers to all the questions through. Thank you so much, everybody. Yes, to people who are asking about copy of slides and things like that, I'll send information about where the recording's hosted for any colleagues, and also slides as well. So you will get those. Thank you so much. It's a wrap. Have a lovely rest of the week, everybody, and thank you so much.